diseases, more common diseases of salivary glands. And this is a short lecture. This is with maybe 20% discount you are expecting this year. So this is a lecture with a discount. Start with question. First question. I'm waiting for other students who are in the process of joining the new link. Yes, Bushra is asking if they only need to read slides, or I will be asking questions from other stuff as well. I will be asking questions from other stuff as well, what I explain. And in addition, you should also look your reference book, that is Robbins. It is not a big topic in Robbins. At least you should go through at least once or twice through Robbins, so you get a taste of pathology, how pathology feels. So although I keep my questions simple at this level because you are not very much into the clinical subjects yet, but you need to go through at least once or twice this basic Robbins. So it seems an easy question for you. Everybody is responding it as A, so the answer is A. Given the picture of a patient when asked to smile, he underwent right parotidectomy. Parotidectomy is removal of parotid gland for any diseases. A few days ago for pleomorphic adenoma. So pleomorphic, I will explain, is a benign tumor because it is adenoma. So it is a benign tumor of the salivary gland. He denies any changes in the taste. Which one of the following is the most likely underlying cause of his presentation? Now, there are two plausible causes. One is facial nerve damage during surgery, and the second is facial nerve damage due to a neoplasm. Because it is facial palsy, there is loss of function of the muscles of facial expression. And because the loss is involving forehead, so is it upper motor neuron lesion or lower motor neuron lesion? It is. It is lower motor neuron lesion. Very good. Because in upper motor neuron lesions, forehead is spared because of dual supply. So it is a lower motor neuron lesion. Now, it can be a cause. It can be a possibility damage to the neoplasm if I change this benign tumor with a malignant one, because malignant tumors, they can invade nerves and they can destroy nerves. So then it becomes a possibility because it is a benign tumor which was present in this patient. So this is a less likely cause. Now, glossopharyngeal nerve is not related with muscles of facial expression, although it supplies the parasympathetic fibers, but it is not to the parotid, to the glands, to the these salivary glands, but it is not involved in the motor function. Fibrosis of the surgical scar can cause deviation of the mouth, but then it will be towards the side, and it takes time. It takes months and years because surgical scars sometimes they can contract, but then they can cause deviation um, of the mouth because of contraction, but then it will be on the same side. Second question. Yes, again an easy question. A 40-year-old lady presents with dryness of the mouth for 2 months. The tongue is shown and tongue is showing dryness and these cracks and fissures. She also complains of burning and itching of eyes. She denies any significant joint pain or deformity. On examination, her parotid glands are slightly enlarged and non-tender bilaterally. Biopsy of her bilateral, enlarged, non-tender. Biopsy of her oral mucosa reveals damaged salivary glands surrounded by lymphocytes. Which one of the following is the likely diagnosis? Now, why not A? Why not acute suppurative saladinitis? It will be tender and it will be then of short duration. When it is acute, it will not be for 4 months and then it will be tender. A viral saladinitis is again, it will be for a few days. It can be for a few days. Sialolithiasis, uh, when it involves, it can cause dryness, but it will cause dryness of that specific part in which that gland drains. That gland secretes its secretions. So only that part will show dryness. It will not be a generalized dryness of the mouth. Shogun Syndrome is correct answer. I will describe it later on. I will describe all these diseases. Xerostomia is not a disease; it is symptom, and it is exactly shown in this tongue and this type of oral mucosa dry with fissures is known as xerostomia. Zero is dryness, stomium mucosa, oral mucosa. Now, in this lecture, I will describe different types, causes, and clinical features of saladinitis, different types of saladinitis, acute and chronic, clinicopathological features of Shogun Syndrome, classification of salivary gland neoplasms with their relative incidence. I will not go into detail of many, but I will describe two: pleomorphic adenoma and Muco-Epidermoid Carcinoma. These are the two common salivary gland neoplasms. One is benign and other is malignant. Now you already did this. These salivary glands they are divided as major and minor. Major salivary glands are three pairs on each side: parotid gland, submandibular gland, and sublingual gland. Parotid is the largest and linguist is the smallest among major salivary glands. And minor salivary glands, they are not named, they are innumerable, and they are spread throughout the oral mucosa. Now, it is an exocrine gland, so it has a duct, and that duct can be blocked by stones or by food particles, by dehydration, by inflammation, by trauma. So, blockage of this duct can cause many diseases. Now, this is microscopic appearance. These are the acini of the parotid gland. Parotid glands are of two types. Both are shown in this picture. These, these are mucus secreting cells, these lighter cells, and these are serous fluid secreting cells. And because it is an exocrine gland, so this is duct, so these are ductular lining cells. And although not very clear in this picture, it is true for all the secretion of all the secretory organs, where acini are not lined by a single layer. They are lined by two layers. Outer, this is epithelial cell layer. It is surrounded by a thin myoepithelial cell layer. Now, these myoepithelial cells, when they contract, they cause expulsion of secretions of salivary glands. Now, these myoepithelial cells are under the control of parasympathetic stimuli. When they are stimulated, these myoepithelial cells contract and they cause secretions. So anything that interferes with parasympathetic stimulations, like a parasympathetic neurotransmitter is acetylcholine. So anticholinergics will will cause dryness of the mouth and will inhibit secretions of the salivary glands. I will explain it further when describing xerostomia, because some drugs which can inhibit the function of parasympathetic nervous system, they can inhibit salivary secretions, and as a result they can cause xerostomia and dryness of the mouth. And now we turn to specific diseases. This is acute saladinitis. Saladinitis is related with the salivary, and adenitis is glands and inflammation. So salivary gland inflammation. And this is a cystic cavity on the inner side of the lip. And this cyst is filled with mucus secretions from salivary glands. Now this occurs, and this is microscopic picture of a similar lesion. These are normal salivary glands, and this is a cystic cavity, and this cystic cavity is lined by these inflammatory cells and the granulation tissue. So this is normal structure of this this type of saladinitis, which is known as mucocele. It is mucus containing and it is cystic. So it is mucocele. So cystic structure which contains mucus. It is a fluid-filled cavity due to destruction of or blockage of duct. Because, as I mentioned earlier, they are exocrine glands, they have duct. So for any reason, if duct is blocked because of some stone, because of infection of some food particles, because of some trauma, some punch during fight, that duct can be blocked and ruptured. So as a result, the secretions will accumulate in the surrounding tissues, causing this cyst formation. Now, any cystic structure fluctuates. So this will be a fluctuating swelling at lower lip. And because duct is blocked, it may increase with the meals. Because during meals, as the secretion, as the salivary glands will secrete saliva, it will accumulate in the surrounding structures, and then it will increase in size. And it is the most common type of acute saladinitis. Now, another type of acute saladinitis is infectious saladinitis. It can be viral and bacterial. Now, viral, you all know, is most common and famous. Mumps and microbiology people will deal with it. But I want to emphasize 2-3 things. In children, it is usually self-limited. Enlargement of the parotid gland for a week or so, and then it disappears. But if it occurs in adults, it can cause complications. And some of the examiners are very fond of asking these complications because it not only causes saladinitis, it can cause meningitis, it can cause pancreatitis, it can cause orchitis leading to sterility. So these are the complications which are related with the acute viral saladinitis. Now, bacterial infections, when they are acute, they are usually because of ductal obstruction. And ductal obstruction may be caused by cyalolithiasis. Lithiasis is stone. Stone in the bile, in the in the duct, in the salivary gland duct is cyalolithiasis. Edema because of the swelling of the surrounding structures, because of the injury, because of the inflammation, and these ducts can be blocked. Food debris in old people, in debilitated people, or persons, it can be a cause. Dehydration can be a cause of infection of something in these ducts, and then they are invaded by Staph aureus and Streptococcus viridans groups organisms. And because it is related with obstruction, it is usually localized, unilateral, and it is acute, so it should be painful enlargement of the gland. And because these organisms are pyogenic, so you can find pus when you press on that swelling. Pus can come out of the in that area. Now, chronic saladinitis is not that common. I will explain in my next slides. So is Shogun syndrome. It is very important, although it is not as common as well, but it is important because you may find it around different specialties: ENT people, pathology people, microbiology, immunologists. They all will keep talking about Shogun syndrome. So I will describe it. Now, this is a picture of acute saladinitis. Acute inflammations usually affect submandibular glands because of its dependent location. And this is swelling of submandibular gland, and most probably it is caused by a stone in the duct. This bluish thing is a stone, and because of the blockage by the stone, this surrounding tissue is necrosed. These pinkish areas are necrosed, and in between these pinkish area, these bluish dots are inflammatory cells. So this is acute inflammation. These are all neutrophils. So these are inflammatory cells, and because neutrophils can cause necrosis of the cells, so there is necrosis. So as a result, this will cause acute saladinitis. Usually, it resolves with antibiotics and with proper rehydration of the persons, but sometimes it persists. And like all the chronic inflammations, then it is replaced by inflammatory area is replaced by fibrosis. This is all fibrosis, fibrous tissue. Even gland is destroyed, and intervening stoma is replaced by fibrous tissue. So less glands, more fibrous tissue, and over time, this may lead to gland fibrosis, loss of function, lack of secretions, and in time it may actually reduce in size. So actually, salivary glands may not be visible even because fibrosis contracts, so they may reduce in size. Now, xerostomia, as I already explained, is dryness of the oral mucosa, and Sjogren's syndrome is one important cause. But there are other causes as well, and drugs like I mentioned, drugs which are anticholinergics, atropine, drugs which are diuretics, which cause dehydration of the patient, like diuretics. You will study diuretics, antipsychotic drugs. So they all can cause xerostomia. Radiation is sometimes used for treating some head and neck cancers. So radiation can damage these salivary glands and ducts of these salivary glands. Then it can lead to dryness of the mouth. And when there is xerostomia, there will be decreased production of saliva. It will lead to dryness, fissuring and ulceration of the oral mucosa tongue, and it will lead to difficulty in swallowing because this is normal function of saliva to lubricate, to digest, to work as an antiseptic. It has IgA, it has lysosomes, so it has protective effect. So as a result, there will be difficulty in swallowing. And there will maybe dental caries and candidiasis-like infections. Now, Shogun Syndrome is an immune-mediated destruction of the exocrine glands. So it is immune-mediated inflammation, and that inflammatory process then leads to destruction of the salivary glands. It not only affects salivary glands, but it affects other exocrine glands as well. And most importantly, lacrimal gland. Lacrimal gland is responsible for tears. So as a result, it can destroy salivary secretions, and it can dry eye secretions. And now it can be primary or secondary. When it is primary, it is an isolated disorder. It is not associated with any systemic disease. It is when it is an stand-alone process of exocrine gland destruction. And exocrine glands are not limited to eye and oral cavity. They can be in the respiratory tract. They can be in the genital tract, vagina. There are many exocrine glands. So it can cause destruction of many glands, but when it is without systemic involvement, it is called primary Shogun syndrome or Sika syndrome, syndrome of dryness. Sika is dryness, and it can be secondary. And in majority of the cases, it is secondary to some other disease, some other immune-mediated disease, and most common immune-mediated disease associated with Shogun syndrome is rheumatoid arthritis. SLE is also seen in some patients. Like most of the immune-mediated diseases, it is more common in females and in their 50s. The symptoms of this Shogun syndrome, if it is secondary, it will have symptoms of joint pain and other connective tissue disorders. But if it is primary, the symptoms are xerostomia, dry mouth, dry eyes, causing keratoconjunctivitis sicca. So kerato is cornea, conjunctivitis is the mucosal layer of the eye, sicca is dryness. So xerostomia and keratoconjunctivitis sicca, and enlarged salivary and lacrimal glands because of the inflammatory process. So these are the clinical features. You can diagnose it as I showed in my MCQ by a biopsy in which these glands are surrounded by intense lymphocytic infiltrate. Now, another way is to identify antibodies against two ribonucleoprotein antigens. So these are the antigens SSA, which is more sensitive, and SSB, which is more specific. But they are not very specific because they are found in other connective tissue disorders as well, like SLE, but they are helpful in the diagnosis. Definitive diagnosis is a lip biopsy, which will show destruction of the salivary glands with lymphocytic infiltration. Now, what is the underlying cause? We don't know, like most of the immune-mediated diseases, but it is thought that it is in the presence of some genetic factors like a specific type of HLA alleles. When viral infections occur, they cause destruction of the salivary glands. As a result, they expose new antigens from DNA, from histones, from RNA to the lymphocytes. And lymphocytes take them as foreign and they react against them. So self-tolerance is lost in those persons. So an immune response works body's own cells. But exact cause is unknown. Now to summarize, any viral infection leads to cell death, release of self-antigens, and these self-antigens are taken as by the lymphocytes as foreign, and they are activated against them, and especially it is thought that it occurs in the presence of some HLA types, specific HLA types. So it has a genetic component as well. As a result, there will be inflammation, withstanding with immune pathology. The risk of B cell lymphoma is 40-fold increased in patients of Shogun syndrome. Now, lymphoma is a lymphoid malignancy. Now, because of the proliferation of these cells, because of immune stimuli, these cells are prone, lymphocytes are prone to genetic abnormalities, and as a result, they develop B cell lymphomas. Now, this is an enlarged parotid gland in a patient of Shogun syndrome. Typical picture: a female of around more than 50 years, a large parotid gland. You may also find enlarged lacrimal glands, dry mouth, and under the microscope, you can see all the gland is destroyed and is replaced by lymphocytes. So these all are lymphocytes. Along with that, inflammatory cytokines stimulate a ductular epithelium. So ductular epithelium is proliferated and it is enlarged in size. So this is a duct. Ductal epithelium is increased, ductal lining epithelium, and glandular epithelium is gone, and it is replaced by lymphocytes. If you find if you like to find further explanations, explanation of these histopathological pictures are included in the footnote of these presentations. So you may find these descriptions in footnotes as well. Now, the last topic, which is neoplasms. Now, neoplasms are relatively uncommon. They are not very common, and slightly they are more common in females as compared to males. And most of them occur in parotid glands. And but luckily, in the parotid glands, only 15 to 30% are malignant. A vast majority is benign neoplasms, while 70 to 90% are malignant in sublingual gland. So roughly, smaller the gland, greater the chances of malignancy. So smaller the gland involved, greater the chances of a malignant development. As, and because most of these tumors arise in parotid gland, so most of them are benign. Now, generally, we know that benign tumors are well circumscribed. They have capsule and they grow slowly. So is true for benign neoplasms of parotid gland and other salivary glands. But sometimes this does not hold true, and morphological evaluation, that is biopsy, is the definitive answer in some cases for the definitive diagnosis and differentiating among these tumors. Now, although salivary glands are basically host of a large number of neoplasms, around 30 types of neoplasms can arise in salivary glands, but a majority of them are these ones. So pleomorphic adenoma makes 50% of all the enlargements of the salivary gland, all the neoplastic enlargements of the salivary glands. Warthin tumor and other benign tumor is 5 to 10%. Muco-Epidermoid Carcinoma is the most common malignant tumor, and followed by adenocarcinoma, which is 10%, and there are other specific types of adenocarcinoma, actinic cell carcinoma, adenoid cystic carcinoma. They are rare. For you, you should know that pleomorphic adenoma is the most common benign tumor. Muco-epidermoid carcinoma is the most common malignant tumor. Now, pleomorphic adenoma is tumor of parotid gland, and because of that, most of the parotid gland tumors are benign. And the origin of this tumor is controversial, but it is thought that they arise from the myoepithelial cells. A characteristic of myoepithelial cell is that they are multipotent. They can differentiate along different mature cell types. They can form epithelial cells and they can form mesenchymal tissue. So that's why this tumor represents a divergent differentiation. So some cells differentiate along mesenchymal lines, while other cells differentiate along epithelial lines. So it is a mixed tumor. So you will find different types of tissue like cartilage, bone, connective tissue, other connective tissues, chondroid matrix, epithelial cells, myoepithelial cells. So it is a mixture of different types of cells. That's why it is known as pleomorphic, multiple structures, or mixed tumor. It is also known as mixed tumor. Like all the benign tumors, they are mobile, means they are not fixed to the surrounding structures within the salivary glands. This is a feature of malignancy. Immobility is feature of malignancy because of the invasion of the neoplasm into the surrounding structures. When they invade the surrounding structures, they become immobile. So these are benign, so they are mobile. They are painless because they are not inflammatory growths, and they are circumscribed masses at angle of the jaw in front of ear or just below ear. So this is their gross description or clinical features. A clinical issue with these tumors is their recurrence. When they are treated and they are excised, they recur at the site, at that site. The reason for recurrence is that these tumors, although they appear very well circumscribed and capsulated, microscopic extensions of the tumor extend beyond capsule. So although grossly I will show you, grossly they appear as if they are limited by the capsule, but microscopically it actually invade into the surrounding structures. Uh, Although it is limited invasion in the surrounding structure, but it does, and it goes beyond capsule. A second thing is that a facial nerve passes through the gland. So sometimes it is not possible for the surgeons to remove that surrounding normal tissue, because these tumors are surrounded by normal tissue, and surgeons try to remove not only this tumor but a part of surrounding normal tissue. Sometimes it is not possible for the surgeons to remove that surrounding tissue. But the answer is wide margin excision. When we say wide margin excision, we mean we remove tumor and we remove some part of the surrounding normal tissue, so that we make sure that all these microscopic extensions, small extensions which are outside the capsule, they are also excised and they are also removed. Now, malignant transformation of these pleomorphic adenoma is not a common feature, and it depends on the duration of benign tumor. It is, for example, if tumor is there for less than 5 years, there are little, if any, chances, less than 2% chances of malignant transformation. But if it is there, because it is slow growing and sometimes stays there and it is not removed. So if it is there for 15 years, chances of malignant transformation are around 50%. So malignant transformation, risk of malignant transformation is there, but it is time dependent. And facial nerve palsy is a sign of malignancy. When it involves facial nerve, it is a malignant. So that is an important clinical clue. It is it basically it is a painless mass, so it does not cause a lot of problems to the patient. Sometimes patient avoid are not willing to get removed these small tumors because they are painless and they are not causing any harm, and they are in this in a very vital area. Sometimes they are not treated for long periods. Now, this is a gross appearance of pleomorphic adenoma. It seems well circumscribed and encapsulated as well. So, grossly, it is the well circumscribed tumor. Now, this is a scanner view. This bluish is tumor. This is normal salivary gland. This is normal salivary gland. This is tumor, and this is capsule of this tumor. Although it appears that it is circumscribed, but some parts of this tumor are going beyond this capsule. What surgeons do normally, they tend to remove a tumor with the capsule of the benign tumors to minimize the injury. Sometimes they even enucleate. They remove the tumor and keep capsule intact because capsule is not part of the tumor. It is compressed surrounding normal tissue. So to minimize the injury. But in this case, it is necessary to remove it by a wide margin. Now this is microscopic appearance. You can see this is cartilage-like mesenchymal tissue. It is myxoid tissue, myxoid stroma, and or chondroid stroma and cartilage-like stroma. And these are epithelial cells. Some of them are myoepithelial cells. So because of this varied morphology of the components, it is known as pleomorphic adenoma. And now, finally, this Muco-Epidermoid Carcinoma, it is most common malignancy of the salivary glands and 15% of all tumors. And it is again like pleomorphic adenoma, it is again an X admixture. It is mucosecreting cells, epidermoid, skin cells, squamoid cells. So it is combination of squamous and mucus-secreting cells and intermediate cells which are both mucus-secreting and squamoid looking. So these are squamoid cells, squamous looking cells, and these are mucoid cells. These are mucoid cells, and this, for example, this is combination of and this is an intermediate cell. So it is combination of squamoid cells, mucoid cells, and epidermoid. This is mucoid and this is epidermoid. It commonly involves facial nerve. So malignancy, again, because it is malignant and it involves facial nerve. Now prognosis of this tumor is dependent on grade. If they are low grade, a 5-year survival is excellent with only few recurrences, and if it is high grade, then 5-year survival is less than 50%. So it is an aggressive tumor if it is high grade. And now this is an algorithm for all salivary gland swellings. It they can be acute or chronic, and if they are acute, they can increase in size with eating, or they don't increase in size with eating. If they increase with size in eating, there is some sort of stasis. It can be some salolithiasis or some injury to the duct or a blockage of the duct, any type of stasis. And if it is constant and painful, erythematous and unilateral, then it is acute swelling. It means swelling of short duration, and it does not change with eating, and it is unilateral, then it is infectious, acute saladinitis, acute suppurative saladinitis. And if it is diffuse, bilateral, acute, then it is viral. So like mumps. So in mumps, it would be acute swelling, and it will be painful. It will be bilateral. And if it is a chronic swelling of long duration, and if it is bilateral, then it is Shogun Syndrome, autoimmune mediated, because it will involve all the glands. And if it is unilateral, it can be diffuse or it can be circumscribed. If it is diffuse unilateral, it is chronic saladinitis, and if it is circumscribed, it is pleomorphic adenoma. So that's how clinically, although it is not important for you clinically, but just to give you an idea, uh, to think clinically, how you think in terms of patient. If patient presents with acute swelling, you look for these things. If patient present with chronic swelling, you look for these things, and that's how you lead to an ultimate diagnosis. MCQ for you. So it is easy. This is a pleomorphic adenoma. Because it is pleomorphic adenoma, it does not usually damage facial nerve. This is a sign of malignancy. Most common in parotid gland. Most common, it is a benign tumor, has epithelial and stromal components, is caused by mumps infection, very easy. So, most common in submandibular gland. No, it is salivary gland. Pleomorphic adenoma is most common in parotid gland. It is not in submandibular gland. So to summarize, mucocele is a fluid-filled cavity due to destruction or blockage of duct, and it is a common cause of inflammation. Streptococcus aureus and Streptococcus viridans groups are the most common causative organisms in bacterial saladinitis, acute suppurative. It usually occurs in the presence of some sort of obstruction or dehydration. Shogun Syndrome is immune-mediated destruction of exocrine glands. It can be primary or secondary to other autoimmune diseases like rheumatoid arthritis and SLE. Pleomorphic adenoma is a slow-growing tumor, most common in parotid gland, composed of mixture of epithelial and stromal components, and it has a tendency to reoccur. Thank you very much, and I will take your questions now. And I finished it in 15 minutes, 15 minutes earlier. So let me see what are the questions. What is the arrow pointing towards? I don't know where is the arrow. Where is the arrow? In which slide? What do you mean by arrow? Slide 17. Let me see what is slide 17. Slide 17 is arrow. Where is the arrow? Slide 17. Is there any arrow? I don't see any arrow. Slides of saladinitis. This arrow is pointing towards a stone. This is a stone. It has probably impacted or blocked a bile duct. This is a blocked duct, and this stone is stained as bluish, maybe because of deposition of calcium, because stones are formed of calcium, so they are bluish. Thank you. And what is the answer to the last question? What was answer for last? It is D. Footnotes for histology slides are enough for our SAQ. Will not ask much histology. D, it is painless. What it does? Fissuring. Fissuring means fissuring means cracking, formation of small gaps, as is shown in the tongue. These small lines are small fissures. These lines are small fissures. Please, can you repeat the histoslides? So, which histoslides? Histopathology slide or histoslide? This is histoslide. This is histology slide. You mean this? This histology slide is showing you mixed salivary gland. Now, some of the salivary glands are serous, some are mixed, while others are mucous. Parotid is, for example, is serous, predominantly serous. As you go smaller, these glands become predominantly mucus secreting. This is a midway, which is showing both mucus and serous cells. So these darker purplish cells are serous cells which secrete serous fluid, while these lighter cells, they are mucus cells, and they are because mucus is washed out during processing in slide preparation, so they appear light colored. And this is their lining epithelium, which is secretory epithelium. They have a second epithelium, which is contractile epithelium, that is composed of myoepithelial cells. Yes, fluctuations. What does fluctuation means? Fluctuation mean what in Arabic? Fluctuation, when you press anything that contains fluid, you can feel that movement on the other side. Like if you push on a balloon which is filled with water, you will feel that movement of the water on your other finger of your other hand. That is fluctuation. You can see it. It is simple English. You can see it in the dictionary. It is not a technical word. Any questions? If Mais, are you there?
Yes, doctor.
They want to ask any questions, they can raise their hands, they can ask questions, they can
Yes, they're free to unmute themselves.
okay. So, okay, thank you very much. So it means no question. Anyways, you can ask more questions if you have any on email and or WhatsApp, whatever you like. You are always welcome.
Thank you very much, doctor.